Ladies and gentlemen, thank you very much for having me in this fetal imaging and beyond course. My name is Przemysław Kosiński. I'm an obstetrician. I work in Medical University of Warsaw in Poland, and I'm going to present my lecture on prenatal evaluation of congenital diaphragmatic hernia and the selection of patients for fetal interventions. So first of all, we need to start with the definition of diaphragmatic hernia. So congenital diaphragmatic hernia is a birth defect where the diaphragm, a thin muscle that separates the chest from the abdomen, is not formed properly. And this allows the abdominal contents to move up into the chest and compress the lungs and the heart. Basically, there are three types of congenital diaphragmatic hernia. Bogdalek type, which involves an opening on the back side of the diaphragm, and this is the most common type of the defect, and typically it's more frequent in male fetuses. Second type is Morgani hernia, which involves an opening in the front of the diaphragm and just behind the breastbone. And the most rare type of congenital diaphragmatic hernia is bilateral hernia, which is the most severe and usual fetal type of CDH. It's very important to know that most cases of congenital diaphragmatic hernia are isolated cases. Roughly 70% of all cases of diaphragmatic hernias are isolated cases, so there's no other anatomical or genetic abnormality. So if you measure crown rump length in the first trimester, you can see pretty normal baby. But if you have a closer look and if you have a nice cross section of fetal chest, even at this early stage of pregnancy, you can see a heart that is shifted in the chest, and you can see a hypoic structure just behind the heart, which is the stomach. So this means that CDH can be diagnosed as early as in the first trimester. So please, when you scan a patient at 12, 11 weeks, please do not focus only on the nuchal translucency or the nasal bone, but also assess properly the anatomy of the baby. Have a look at the stomach and have a look at the chest and the position of the fetal heart. It's very important to know that in most cases, CDH is not related to genetic problems, but roughly 30% of all cases of diaphragmatic hernias might be associated with chromosomal defects such as trisomy 18, tetrasomy 12p, which is Pallister-Killian syndrome. Congenital diaphragmatic hernia is most commonly diagnosed by ultrasound in the second trimester of pregnancy. But still, have a look at the anatomy of each baby at 11, 12 weeks as well. So this is the typical cross-section of fetal chest at roughly 12 weeks during the anatomy scan, anomaly scan. You can see the heart that is shifted to the right, because this is the case of left-sided diaphragmatic hernia. So the opening in the diaphragm is on the left, therefore the shift of the heart is to the right. You can see stomach, which is hyperechoic structure just behind the heart, and you can see also the part of the liver and the bowel. This is a very typical cross-section of baby's chest with congenital diaphragmatic hernia. This abnormality is diagnosed roughly in 1 in 4,000 live births. Once the diagnosis is confirmed, the genetic investigation should take place to exclude genetic background of the abnormality. Here is a short list of genetic syndromes where CDH may be a part of clinical picture. Karyotyping is the basics, because you can exclude trisomy 13, trisomy 18, and tetrasomy 12p, which is polycercilian syndrome. But still, geneticists recommend microarray testing for all babies with CDH. This is due to the fact that sometimes CDH might be the only symptom of genetic abnormality. It's very important to understand that congenital diaphragmatic hernia is one of the most severe birth defects with extremely high mortality rate. Congenital diaphragmatic hernia is therefore not just an opening in the diaphragm. The consequences of this birth defect are in many cases fatal and a result of reduced number of airways, abnormal pulmonary vessels, and pulmonary hypertension and lung hypoplasia. Lung hypoplasia is the most common reason for these babies to perish. Roughly in 1 up to 2% of cases, babies with congenital diaphragmatic hernia may perish even in utero. Unfortunately, it's not possible to predict the outcome in a very precise way. There are a number of publications of ultrasound, Doppler, and even MRI markers that might be useful in the prediction of the outcome of babies with congenital diaphragmatic hernia. You can see a short list of different scientific papers with different ratios and markers, but unfortunately there's no just one perfect and ideal marker that will predict the risk of pulmonary hypertension and pulmonary hypoplasia. But on the other hand, there has to be a way to distinguish mild cases from severe cases. So once the diagnosis is made, there's a need for severity assessment. Despite increasing availability of MRI scans, it still seems that the most available and reliable technique is the ultrasound. The first ultrasound marker for the severity assessment of CDH babies was LHR, described in 1996 by Meticus. This marker is fairly easy to measure, but unfortunately it's gestational age dependent. Cases with LHR above 1.0 are considered as mild cases of CDH, and cases with LHR below 1.0 are considered as severe cases. There was a study of 650 normal fetuses which described the growth of the head and the growth of the lungs of fetal chest in normal conditions. And within this paper, there was 18-fold increase in lung area, but only a 4-fold increase in head circumference described. And therefore, LHR was confirmed as gestational age dependent index. So another one was described, and that was observed over expectant LHR, which is also fairly easy to measure and is less gestational age dependent. This index is expressed in percentiles, So cases with observed over expectant LHR above 25% are cases of mild CDH, and cases of observed over expectant LHR less than 25% are considered as severe and extremely severe cases. Another ultrasound marker less frequently used in clinical practice, but in some cases useful, is QLI. And the biggest advantage of this index is that the 50th percentile of this index is consistent throughout the pregnancy and approximately is 1.0 for all babies between 16 up to 32 weeks. So the authors who presented this index defined small lung, which is severe diaphragmatic hernia, as less than 1 percentile, which means QLI less than 0.6. In my previous slide, you have just heard that LHR is fairly easy to measure, but it's very important to understand that there are different methods of making the lung measurement. The lung might be measured in anterior-posterior method, the longest diameter method, and the tracing method. It has been proved that the latter, which is the tracing method, is the most reliable one, as the longest diameter method overestimates the right and left lung by about 45% compared to the tracing method. Therefore, it's very important to make the measurements always in the same manner, and it's very important that the measurement is taken by an ultrasound specialist who is experienced in taking these measurements. As you can imagine, the measurements are very important, and the methods of measurements are very important because depending on LHR, observed over expectant LHR, we divide patients into groups of severe and mild cases. The outcome is different and the counseling is different. There have been many papers published that proved the differences in different measurements. So you need to make sure that you learn how to measure the lung and make sure that you choose the method that is more accurate. There is another marker that is very important in terms of the counseling and in terms of the prediction of neonatal death and the prediction of lung hyperplasia. It's the liver position. In cases of severe cases where the opening of the diaphragm is big, the risk of the herniation of the liver is greater. So once the diagnosis of CDH is made, it's very important also to assess the position of the liver. This can be done using ultrasound with the help of the color Doppler. But there is a very useful marker that helps to establish liver position in babies with CDH. So this marker is umbilical vein deviation angle. It has been described by our friend Nicola Volpe from Italy, and it's very useful in detection of congenital diaphragmatic hernia, but also is very useful in clinical practice in terms of distinguishing whether the liver is down or up. So umbilical vein deviation angle is when you assess the degree of kinking of umbilical vein. With the sensitivity of 98% and specificity of 100%, you can distinguish babies with liver up using the cutoff of 15 degrees. So once you have assessed the position of the liver, you have calculated observed over expectant LHR and LHR, you know that your case is severe or mild diaphragmatic hernia. In the most severe cases of congenital diaphragmatic hernia, which represents observed over expectant below 25%, the survival rate is extremely poor due to high risk of pulmonary hyperplasia. Therefore, this group of patients is fit for fetal intervention, such as fetoscopic endotracheal occlusion, which is FETO. The idea behind the airway occlusion is based on the ultrasound observation of another extremely rare congenital abnormality. In cases of congenital high airway obstruction syndrome, chaos, airwaves are blocked and lungs are filled with fluid and therefore enlarged and hyperechoic, with the heart just in the middle of the chest due to the compression. In cases of congenital diaphragmatic hernia, lungs are too small. Therefore, it has been assumed that blocking the airwaves will produce larger lungs. FETO procedure is performed using minimally invasive technique by ultrasound guidance, which means that the ultrasound is used to identify the best place to enter the uterus. Once this is established, fetoscope is introduced and directed into the baby's mouth and then into the trachea, and the balloon is placed in the windpipe right above the separation into two sides of lungs. The balloon is typically left in place for 4 to 5 weeks. It is typically electively removed by the second fetoscopic procedure at approximately 34 weeks. You can see the video of the balloon placed in the trachea. You can see that the balloon is inflated, and then the catheter is released and the balloon stays there for roughly 5 weeks. In this video you can see the second procedure, which also involves fetoscopy. From patient's perspective, it looks roughly the same. And the aim of this procedure is first balloon puncture and then its removal. This procedure is typically performed at 33-34 weeks of gestation. You can see on the left-hand side panel a balloon punctured with a needle during fetoscopy, and on the right-hand side panel you can see a punctured balloon removed with forceps. The history of prenatal interventions for CDH babies is very interesting, with many ups and downs and many turning points. Some of the developments changed the clinical practice, like introduction of minimally invasive technique and the fetoscopes, like introduction of LHR and observed over expectant LHR. But I would say that the most important turning point in the care of babies with CDH was the total trial, which is the only randomized trial on CDH babies and fetal intervention. It has been more than 10 years for this study to finish, and many centers were involved in this study. But since the publication of this randomized trial, fetal surgery for severe left diaphragmatic hernia, and the results were published in New England Journal of Medicine, it has been shown that fetal procedure increases the survival rates with a slightly increased risk for preterm birth and pre-labor rupture of membranes. This was a randomized trial, which means that there were two groups of treated and untreated with fetoscopy patients, and the main driving force from Professor Ian Deprest, who was the primary investigator of this valuable study that was conducted in 2008. Since the publication in New England Journal of Medicine, with no doubt, this procedure has been proven as effective in increasing survival rates in the most severe cases of congenital diaphragmatic hernia. So the protocol that we introduced in the clinic I work in is the basic assessment of the pregnancy at 20-22 weeks once the patient is referred to our clinic, and then amniocentesis is performed to exclude the genetic problems, preferably with microarray, and then reassessment takes place at 24-26 weeks, just before the fetal intervention. In cases with observed overexpectant LHR of less than 25%, fetal procedure is offered. In cases of observed overexpectant LHR of above 25%, so in cases of mild diaphragmatic cases, you still need to monitor these babies and monitor the amniotic fluid index. This is due to the abnormality which is more likely to cause the polyhydramnios. Polyhydramnios might increase the risk of premature rupture of membranes, and therefore in cases of severe polyhydramnios it is recommended to perform the amnioreduction. Within the last 10 years of our experience with fetal interventions in congenital diaphragmatic hernia, I learned many things. One of the most important things I learned was that patients after fetal procedure, they have to stay on site. They must not travel, they must not go back home, they have to stay close to the hospital. There is a percentage of patients who will have some pain, who will have contractions, who will have premature rupture of membranes, and these patients, they have to be on site, and there has to be a team of doctors ready to take the balloon out. So that's why we have very nice cooperation with Ronald McDonald Foundation, and all our patients, they can stay on site very close to the hospital, and the team of doctors is ready to perform the fetoscopy and to take the balloon out. Another very important thing I learned is the teamwork. So it's not just the ultrasound, it's not just the counseling, it's not just the fetal intervention, but it's the cooperation of the surgical team, neonatal team, and obstetrical team. And that is the only way to achieve a good result. The management of babies with CDH is complex, and involves several teams to work together hand in hand. Perinatal team performing ultrasound scans, fetal procedures, and patients follow-ups. Obstetrical team who plan the mode and proper time of the delivery. Neonatal team who is in charge of the stabilization, the critical care and possible resuscitation and intensive care of the newborn. And last but not least, the surgical team who perform the repair of the diaphragm. It is the only teamwork that leads to increase in the survival rates in the most severely ill babies. I'm very happy to say that the center, the hospital they work in, has established meetings with all these teams all together in one place, one time, and we talk to the patients and we counsel them and we plan as in details as possible the delivery and the management after the baby is born. To sum up, it has to be underlined that CDH is a very severe fetal abnormality with extremely high mortality rate. Still, the ultrasound remains the best method to assess the severity. The most commonly used method to assess severity of CDH is LHR and observed over expectant LHR, with the tracing method being the most accurate to estimate the size of the lung in fetal chest. Gestational age independent index is observed over expectant LHR, and therefore observed over expectant LHR seems to be better than simple LHR. Fetal procedure has been proven in the paper by Jan Deprest, published in New England Journal of Medicine, as the procedure that increases the survival rate. The increase of survival rate is twofold. So the chance of the survival will increase 2 times after the fetal intervention. And what is the most important, it is not just the prenatal counseling, it's not just the prenatal management, but it's the teamwork that is essential to increase the survival rate of babies with CDH. Thank you very much.